In the next section, we'll be looking at the stomach and small bowel and examining the pathophysiology of both of these in some detail. In the next section of the GI physiology module, we'll be looking at the stomach and small bowel and looking at pathophysiology that can occur in those two areas of the GI tract. What you'll often see in the emergency room is patients presenting with hematemesis or vomiting of blood. This is one of the most common calls to a gastroenterologist and most commonly occurs due to peptic ulcer disease. Other causes include esophageal varices, hemorrhagic gastritis, and aortoenteric fistulae. Melena or dark tarry stool occurs when hemoglobin is converted into hematin, which is a black pigment, by acid. This signifies a bleed proximal to the ligament of Treitz and is indicative of an upper GI bleed. Peptic ulcer disease is the most common cause of hematemesis and melena. If any of you do ever become a gastroenterologist, you will receive innumerable calls for both hematemesis and melena. Acute hemorrhagic or erosive gastritis is caused by a number of different factors. The most common clinically that's seen is secondary to the use of non-steroidal anti-inflammatory drugs such as ibuprofen and naproxen. CMV or cytomegalovirus in the presence of HIV virus can also cause a hemorrhagic gastritis. Alcohol and smoking are important risk factors for hemorrhagic gastritis, and in conjunction with the use of non-steroidal anti-inflammatory drugs can precipitate both hematemesis and melena. Curling ulcers or ulcers secondary to the high stress induced by burns can also occur and can result in hemorrhagic gastritis. Again, Cushing ulcers caused by severe CNS injury can also cause hemorrhagic gastritis. This is thought to be mediated by the release of very high levels of catecholamines into the systemic circulation. Uremia in renal failure can also cause acute hemorrhagic gastritis and is one of the reasons that patients with renal failure will often be placed on prophylactic therapy with a proton pump inhibitor or H2 blocker. Clinically, what we find is that patients present with hematemesis or vomiting of blood, melena or the presence of dark, tarry, often offensive smelling stool, and will have iron deficiency. Iron deficiency is less common in an acute bleed, and is more commonly found when there is a slow chronic bleed that's present with loss through the GI tract. Chronic atrophic gastritis is also found in patients and is of two types. Type A chronic atrophic gastritis involves the body and the fundus. As you can see in this diagram, and that's the upper right and the main part of the stomach. It's most often due to pernicious anemia with a loss of production of intrinsic factor. The complications that occur are achlorhydria with hypergastrinemia. In the presence of hypergastrinemia, there is loss of negative feedback because HCl is not being produced. Macrocytic anemia also occurs due to vitamin B12 deficiency, as intrinsic factor is not present to bind to B12, and both of these are required for endocytosis to take place in the ileum. There is also a risk of increased adenocarcinoma in chronic atrophic gastritis. Type B chronic atrophic gastritis involves the antrum and the pylorus. Therefore, this is the distal part of the stomach. So an easy way to remember it is type A chronic atrophic gastritis involves the first part, i.e. the body and the fundus. A comes before B, and B involves the second part, which is the distal or antrum and pyloric part of the stomach. The most common cause is Helicobacter pylori infection. H. pylori is a gram-negative curved rod, and it produces urease, which converts urea to ammonia, and it produces proteases and cytotoxins. The discoverers of H. pylori actually won the Nobel Prize for Medicine in the last few years, and when they first postulated the presence of Helicobacter pylori in the stomach, their theory was generally poo-pooed. It's only when one of the physicians actually infected himself with H. pylori and showed that you could place him at greater risk of developing both atrophic gastritis and peptic ulcer disease that their findings were given the recognition that they deserved. As I've already mentioned, H. pylori produces urease, proteases, and cytotoxins, and these factors combine to produce both chronic gastritis and peptic ulcer disease. Now, what's very important to remember is that with chronic atrophic gastritis, in the presence of H. pylori, it can act as a precursor lesion for adenocarcinoma of the stomach. This is unlike H. pylori infections in the duodenum, where there is not that increased risk for carcinoma. So both type A and type B chronic atrophic gastritis expose patients to an increased risk of adenocarcinoma. The next diagram is the outlining damage and the manner in which damage is caused by H. pylori. So H. pylori comes and goes through the mucus layer and infects the gastric epithelial cells. Here, with its urease activity, it causes the production of ammonia, which can neutralize gastric acid. And by releasing cytotoxins, ammonia, as well as proteases, it causes mucosal damage. As this damage occurs, then further inflammation occurs by gastric acid, proteases, and other effector molecules that are present. As you remember from an earlier lecture, the pH at the cell layer level is 7, and it's only the pH in the gastric fluid or in the lumen of the stomach which is 2. However, when the protective layer around these cells is removed, then direct mucosal damage to these cells can occur, resulting in the formation of both atrophic gastritis and peptic ulcer disease. There are numerous tests which are used to identify H. pylori and are both sensitive and specific. The CLO test detects urease in a gastric biopsy and is often delineated by a color change that occurs in the medium. The CLO test can be read at 24 hours, although it's often positive if H. pylori is present within 1 to 3 hours. There are serological tests looking for H. pylori both in the blood and in the stool with H. pylori stool antigen, and there's a radio-labeled urea breath test. Diseases that are associated with H. pylori are duodenal and gastric ulcers, the type B antral chronic atrophic gastritis. This is distinct to type A chronic atrophic gastritis, which affects the body and the fundus. And H. pylori is also associated with gastric adenocarcinoma, but not duodenal carcinoma. And there is an association with long-term infection of H. pylori and low-grade B-cell lymphomas. So to recap, H. pylori causes both duodenal and gastric ulcers, the type B antral chronic atrophic gastritis, and 2 types of cancers that you need to remember: gastric adenocarcinoma and a low-grade B-cell lymphoma. Peptic ulcer disease occurs both in the stomach and the duodenum. In the stomach, it occurs when there is a breakdown in the protective barrier or the mucus layer which protects the gastric cells. This is not due to acid. This is usually located in the antrum of the stomach and is associated with H. pylori 70% of the time. So as we described earlier in the diagram, H. pylori infection predisposes to breaks in the protective barrier, and therefore stomach acid that is present at normal levels can then do damage to the mucosal layer. This will predispose to cancer 20% of the time, as we said, gastric adenocarcinoma, and it's been shown that there is an association with type A blood. This is important to remember because it's something that can be easily tested. It's very important to scope and biopsy every gastric ulcer to make sure that there is no malignancy present. Clinically, what we will often do is we will go in, if there's a gastric ulcer present and it's bleeding, we will stem bleeding and we may take some biopsies, but we will always go in within a few weeks, in 6 to 8 weeks, to make sure that number one, the gastric ulcer has healed fully, and number two, that biopsies are normal and that there's no presence of gastric adenocarcinoma. With gastric ulcers, the classic teaching is that pain is worse with eating, i.e. as food hits the stomach, although patients often do not read the book, and this is not the case. Duodenal ulcers, on the other hand, are due to the presence of too much acid. This can occur for a number of reasons. This can occur if there's in the setting of Zollinger-Ellison, where there's too much gastric acid production. It usually occurs in the second part of the duodenum, and the pain is often worse after eating and at night. This is, again, unlike gastric ulcers where pain is worse with eating. The way to easily remember this for exam purposes is that the gastric ulcer comes before the duodenal. The stomach is present before the duodenum. So gastric ulcers, pain occurs first, i.e. with eating, and with duodenal ulcers, pain occurs a little later, and it makes sense because it's more distal. H. pylori is associated with duodenal ulcers 95% of the time, and there is no cancer risk. The association that's been shown is with blood type O. And again, this is something that can be easily tested. So, peptic ulcer disease with gastric ulcers is associated with blood type A, and with duodenal ulcers is associated with blood type O. The next table is a comparison of gastric and duodenal ulcers, and we've gone through most of this already. As a quick overview, duodenal ulcers are 3 times more common than gastric ulcers and are more common in men than women. Gastric ulcers have an equal preponderance in men and women. Duodenal ulcers are associated with MEN type 1, for example, when it's called in association with Zollinger-Ellison, so pancreatic, parathyroid, and pituitary tumors, so the pancreatic being the Zollinger-Ellison. Smoking does not cause peptic ulcer disease, but is associated with delayed healing and therefore can predispose patients to developing peptic ulcer disease. And can delay healing, meaning that patients with smoke have a longer course. Duodenal ulcers are present in patients with renal failure and hyperparathyroidism as part of MEN syndrome type 1. Helicobacter pylori is present in 80% of cases of gastric ulcers and 90 to 95% with duodenal ulcers. The important thing to remember about these: with gastric ulcers, it's not due to an overproduction of acid, but due to a defective barrier. And duodenal ulcers are present because of increased acid production, as well as a defective mucosal barrier. Gastric ulcers most commonly occur on the lesser curvature of the antrum, and duodenal ulcers are present on the anterior portion of the first part of the duodenum. When they are present on the posterior portion of the duodenum, they need to be handled very carefully because there is a danger of perforation into the pancreas, resulting in release of stomach contents into the pancreas, potentially resulting in an acute abdomen and acute pancreatitis in these patients. With gastric ulcers, bleeding is a common complication, secondary to left gastric artery bleeding. And with duodenal ulcers, perforation into the gastroduodenal artery can occur with subsequent bleeding. Clinical findings with gastric ulcers are epigastric pain soon after eating, and with duodenal ulcers 1 to 3 hours after eating, although it can often be difficult to differentiate between the two clinically. Zollinger-Ellison syndrome, as we mentioned previously, are usually malignant pancreatic islet cell tumors, where there's excess secretion of gastric acid, resulting in hyperacidity and mucosal hypertrophy. These are associated with multiple endocrine neoplasia, or MEN type 1, in 20 to 30% of cases, where there may be pituitary and parathyroid tumors present as well. Clinical findings in Zollinger-Ellison syndrome are epigastric pain because of the ulcer, as well as weight loss. Peptic ulceration will occur because of increased gastric acid production, and there's increased acid hypersecretion with diarrhea. Maldigestion of food occurs because, as we discussed earlier, pancreatic lipase is affected when the duodenal pH is greater than 4 to 5. In the presence of acid in the duodenum, pancreatic enzyme activity is affected, and patients can present with steatorrhea. Laboratory findings will include a serum gastrin, which is markedly elevated and is often greater than 1,000 picograms per mil. Next, we'll talk about dumping syndrome. And again, patients can present clinically with cramping and diarrhea, as well as sweating and faintness. Dumping syndrome occurs when contents of the stomach empty too quickly into the small intestine, or literally the contents are dumped out from the stomach instead of the nice controlled release that we talked about, which is mediated by hormones such as cholecystokinin. The partially digested food, which is drawn into the small intestine, has an osmotic potential, and therefore it draws fluid into the small intestine. This results in nausea, cramping, diarrhea, sweating, faintness, and palpitations as large fluid shifts are occurring in the body. Dumping usually occurs when there's too much consumption of simple or refined sugar, or in people who've had surgery to modify or remove all parts of the stomach. What this means is that the stomach is no longer able to act as a repository for this food, and mixing with formation of chyme does not occur. And so food is literally dumped out into the small intestine. Early dumping occurs during or right after a meal, and late dumping happens 1 to 3 hours after eating. This is late dumping because, as you know, normally food contents will stay in the stomach for between 3 to 4 hours after a meal. Another thing that's often tested on this examination is congenital pyloric stenosis. This is an inherited disorder with multifactorial inheritance pattern and is present in 1 in 500 live births. There is a predominance of men who are affected, and it's characterized by progressive hypertrophy of the circular muscles in the pyloric sphincter. As this progressive hypertrophy occurs, this means that patients will present within 2 to 4 weeks of birth. It's therefore not present at birth, in contrast to esophageal atresia, which occurs when children present at birth with vomiting after a meal. Clinical findings include projectile vomiting of non-bile stained fluid 2 to 4 weeks after birth, and hypertrophied pylorus can often be palpated in the epigastrium. You may see a photograph in the exam where they'll show you a baby, and in the epigastric region you'll see a little bump. This may represent a hypertrophied pylorus, especially if the story that goes along with it is that the baby started to vomit 2 to 4 weeks after birth. The therapy of choice in congenital pyloric stenosis is surgery to relieve the obstruction. Duodenal atresia is also something that is often tested. This results in obstruction from failure to recanalize the duodenal lumen. The risk factors are trisomy 21 in 20 to 30% of patients. The symptoms are bilious vomiting, often on the first day of life. Duodenal atresia may present later than esophageal atresia because it can take time for food contents to reach the duodenum. There is usually no abdominal distension, and these patients are often associated with oligohydramnios during pregnancy. Steps to diagnosis include an abdominal X-ray where there is a double bubble. The double bubble represents the stomach and the dilated duodenum, and therapy of choice again is surgery. The next diagram just shows a small overview of the duodenum and small intestine. So the duodenum empties out into the jejunum, and from the jejunum into the ileum. At the ileum, there's the ileocecal valve, which acts as a barrier between the large bowel and the small bowel, and food contents from the terminal ileum empty out into the cecum in the large intestine. Intestinal motility has a number of different phases. We will first discuss the intestinal phase. The intestinal phase controls the rate of gastric emptying and begins when chyme enters the duodenum. As food enters the duodenum, this stimulates Stretch receptors and chemoreceptors. These both trigger the enterogastric reflex, which is a short reflex that temporarily inhibits gastric production and gastric contractions. As a pH below 5, secretin stimulation is also stimulated, and this further inhibits gastric acid secretion. Lipids, especially monoglycerides, not triglycerides, and fatty acids, and carbohydrates also stimulate the release of cholecystokinin. This again inhibits gastric emptying. This means that a meal which is high in fat stays in the stomach for longer. There are therefore 3 different mechanisms that are present to control the rate of gastric emptying before chyme enters the duodenum. The enterogastric reflex, which is stimulated by stretch, secretin, which is stimulated by low pH, and cholecystokinin. All of these inhibit gastric emptying. We've been talking about small intestinal motility throughout this module. There are slow waves in the duodenum at a rate of 12 per minute, which decline to 8 in the distal ileum. Peristalsis helps to push chyme towards the large intestine. This is when contraction will occur with relaxation in front of the wave, resulting in propulsion of food. Segmentation occurs to help mix by contraction, so that chyme is moved to and fro to increase its exposure to the mucosal surface. There's also contractile activity of the muscularis mucosa. This alters the ridges and folds of the mucosa, helping to mix the luminal contents up and producing irregular contractions of the villi. This helps to empty the central lacteals which are present, and helps with increased absorption as well. Chyme typically takes 2 to 4 hours to traverse the small intestine, and as has been discussed a number of times, parasympathetic innervation by the vagus strengthens contraction. These nerves also release VIP and enkephalins and motilin. Sympathetic innervation from the celiac and superior mesenteric ganglia weaken contraction. So again, the same theme is present throughout the GI tract. Parasympathetic innervation helps to strengthen contractions. Sympathetic innervation weakens contractions. The small intestine covers 15 to 20 feet. This is a very large area, and the main purpose is for absorption of food substances to take place. Unsurprisingly, one of the big things that can go wrong with the small intestine is when malabsorption takes place. For example, with increased fecal excretion of fat, deficiencies of vitamins can occur. These are the fat-soluble vitamins A, D, E, and K. There is impairment of absorbance of minerals, carbohydrates, and proteins. Causes include pancreatic insufficiency, where steatorrhea can occur, bile salt deficiency, which results in improper micelle formation and can precipitate diarrhea, and small bowel disease. Clinical findings, as we've already discussed, include steatorrhea with excessive, large, sticky, smelly stool that floats, fat-soluble and water-soluble vitamin deficiencies, combined anemias such as folate and iron deficiency, and ascites and pitting edema. This occurs when there is a protein-losing enteropathy present in the GI tract, resulting in decreased oncotic pressure and third spacing of fluid into the peritoneum and into the legs, interstitial space presenting as edema. The pathogenesis of small bowel malabsorption is number one, the inability to resorb micelles because there's a loss of villus surface. This can occur in celiac disease, which is occurs when there is gluten sensitivity and results in flattening of villus surfaces and lymphocytic infiltration of endothelial cells, as well as Whipple's disease, where there is overgrowth with Triphoremi whippleri. In these cases, the villus surface is decreased, and so absorption is impaired. Lymphatic obstruction can also occur, such as, again, in Whipple's disease and in A-beta lipoproteinemia. D-xylose can be used as a screening test, and decreased absorption indicates small bowel disease. Xylose does not require pancreatic enzymes for absorption, and lack of absorption of xylose indicates that there is a primary problem with small intestinal absorption reflecting small bowel disease. General screening tests which indicate malabsorption are, number one, qualitative or quantitative stool for fat. This has to be done carefully because the patients normally have to be on a controlled fat diet for 48 hours before measuring their stool for fat. And there's also decreased serum beta-carotene, which is a precursor for fat-soluble retinoic acid, or vitamin A. This makes sense because, as we already know, vitamin A, D, E, and K are the fat-soluble vitamins. Therefore, if vitamin A absorption is decreased, there will be decreased serum beta-carotene. Small bowel disorders which cause malabsorption are laid out in this table. We've already talked about both of them. Celiac disease is an autoimmune disorder with antibodies against gliadin fractions in gluten. There's a strong association with dermatitis herpetiformis in the skin, and celiac disease usually begins in infancy. It's actually incredibly under-recognized and may be much more common than we think. It's female dominant and primarily involves the duodenum and jejunum. The diagnostic test of choice is a upper endoscopy or EGD with biopsies of the duodenum and jejunum. What we'll see is flattened villi and hypoplastic glands with chronic inflammation and T-cell infiltration. For this reason, patients may present with T-cell lymphoma, but this is unusual except in patients with very long-standing disease. The best way to treat the disease is to restrict or eliminate gluten from diet. And the screening tests are anti-gliadin antibodies or anti-transglutaminase antibodies. Whipple's disease is a male-dominant disease, unlike celiac, which is female-dominant. It's caused by Triphoremi whippleri bacilli, and histologically there's blunting of villi. There are foamy PAS-positive macrophages in the lamina propria, and these obstruct lymphatics and resorption of chylomicrons. Clinical findings include polyarthritis, fevers, lymphadenopathy, and increased skin pigmentation. As this is a bacterial infection, the treatment of choice is with oral antibiotics. In the last section, we discussed the pathophysiology of the stomach and small bowel. For the purposes of the exam, it's important to know about atrophic gastritis and peptic ulcer disease, as these are commonly tested questions.